Hello everyone and welcome to the CIH podcast. It's great to have you with us today. I'm delighted to be joined in this conversation by Aileen Evans, who's Group Chief Executive at Grand Union Housing Group and a member of CIH's board, and by Liz Parsons, who's Head of Public Health for the Built Environment and Social Housing for the Milton Keynes, Central Bedfordshire and Bedford Borough Council Partnership. In today's conversation, we're going to talk about housing and health, a topic that's often discussed, but not always with a clear strategic plan to bring it together. Public health is at the heart of housing management, and indeed where CIH's work on housing started. It was on the back of great work by social reformers who were opposed to appalling housing conditions in the second half of the 19th century that many housing associations developed. From an administrative perspective, housing used to be managed as part of public health's remit, and it was Christopher Addison, the first Minister for Health, who oversaw the expansion of council housing after the First World War. And bringing us up to the current day, recent media coverage of poor quality housing has shone a light on how the condition of homes can affect physical health, as well as highlighting the impact of high housing costs and poor security of tenure on mental well-being. The COVID-19 Marmot Review, commissioned by the Health Foundation, identified health inequalities which were intensified by the housing crisis. In this podcast, Aileen and Liz are going to share some of their experience of bringing health, housing and social care leaders together to develop stronger health and housing partnerships. This feels even more important now at a time of rising cost of living pressures. So, welcome Aileen and Liz. It's great to have you with us. Thank you for giving up your time. I wonder if I can start by asking you to just give us a bit of background as to how you came to work together on this and what you set out to try and achieve. Perhaps I can go to you first, Liz.
Hi, morning both. Good to see you. I think the health and housing work started when I was still based in social housing, and I got an opportunity to take the work forward on the public health side, so to lead it through the shared public health service for Bedford, Central Beds and Milton Keynes. And I was really keen to talk to Aileen at the time because she was a huge campaigner for mental health issues and was CIH president. And so I thought she could be a great advocate for the work. And I also knew that, Grand Union were very committed to putting the customer at the heart of what they do and have a very holistic view to service delivery. So sort of from an early conversation, Aileen kindly agreed to sponsor the work and be an advocate from the social housing side. And from there, things kind of grew. She introduced me to her leadership team and other colleagues in housing. And so that was really just the start. And I think we've found that as we've gone through, that the sky's the limit for this work. So, yeah, it was a very opportune conversation that's led to some great work, I think.
And I would just come in there. Hi, everybody. I would just come in there and say we had been trying to work with health in its broadest sense forever. I can remember talking about it 10 years ago, at least 10 years ago, and we'd done a bit of step up, step down accommodation. We'd worked with health through our work with people with a learning disability and supported housing, but we'd never really managed to crack the nut of how we worked with health in a much more broad capacity because we didn't know what it was. We didn't know how to break in. We kept having conversations that went nowhere because we weren't talking to the right people in the right language. And actually, Liz and I had this conversation and it was one of those no-brainer moments for me. I've had quite a few of those over the last year or so. It was one of those no-brainer moments for me and thought, well, actually, that sounds really sensible. We're in a pandemic. Health is really, really important. Why wouldn't we do something? And so Liz was opening a door that we had been, I think, and not just us at Grand Union, but people in housing generally. Liz had given me a door to open that we've been trying to bang against for ages. And this felt like a really easy, no-brainer way to start it, really.
Excellent. Well, let's hope we can unpack a little bit of what that meant to crack the nut, because it sounds really interesting. So, obviously, this is all about partnership. Can you just talk us a bit through who your key partners are and have been, and perhaps how you've gone about working to bring them together?
Yeah.
Over to you,
Okay.
Liz. Thanks.
Well, I think as we've just said, we started initially with Grand Union, and I think one of the things to mention around the partnership piece that's been so important is recognising and understanding that sort of strategic alignment between things like Health and Wellbeing Board strategy goals, and then things like Housing Association corporate strategy. So, for example, the Grand Union Further Together strategy. So that, from a partnership engagement piece, that's been a real can opener for conversations. Initially, we've worked with Grand Union, and then through Aileen's introductions with Catalyst, and they've been our core partners for the last sort of 18 months, 2 years. We do some other work with some other housing associations locally, and also the housing teams at both Central Beds and Milton Keynes Council, because they've retained their housing stock. But I think, working with Grand Union and Catalyst, we've been lucky enough to establish a 3-year partnership between housing and public health and the shared public health teams that will really benefit people in our communities. And if you look just across Central Bedfordshire, Milton Keynes and Bedford Borough, there's upwards of 80,000 people living in either social housing settings or council housing settings. So the opportunity to engage and improve the reach of this work is massive. And although we've started relatively small in terms of our partnership approach, the goal has always been to create a blueprint for a new way of working between health and housing that can be replicated and scaled up in any setting. And so, through our early partnership work, we test the model in different settings, so retirement living settings, general needs settings, rural, urban, so it's early days, hopefully, but we've covered quite a lot of ground through our partnership so far.
And I was talking to Kirsty Pepper at Catalyst, who is leading on this for them, and Catalyst are now part of Peabody and will be a full part of Peabody next year. So I'm really excited about the possibility that brings. And what we've done really is Grand Union have tried something in a particular location, Catalyst have tried something else. Actually, what we've now got is an opportunity to bring some of that together and to do some more joint work in an area where Catalyst and Grand Union share a footprint, for example, so that we can have a bigger impact. And let me just think that the partnership is so important to us that both Catalyst and ourselves have funded it to the tune of £30,000 a year. But actually, we are already reaping the benefits of that in grant that we've been able to access that we wouldn't have been able to access, but actually, and more importantly, in money we're not spending on estates where we have had some real difficulties, where we've been trying to deal with a whole range of problems through a housing and antisocial behaviour lens, when actually what drives the behaviour is health outcomes. We know, for example, at Grand Union that 75% of our customers live with at least one health condition. 14% of our customers live with 5 health conditions or over. So we're being able to access that public health support and have an in to that support readily available means that, for example, we're not now visiting in twos on an estate that had major issues with drug, alcohol, abuse, violent crime, a whole load of stuff. So there's a natural saving of money, but more importantly, the impact on people's lives, the massive impact on people's lives, it's just huge and kind of almost unquantifiable that somebody's life is better as a result of a conversation that Liz has had with me and said, I've got this idea, will you give it a go?
That's brilliant. And I wonder if we can just take that a little bit further in thinking, so how does that position you through this partnership as you look to the sort of the winter that's coming? There's obviously a huge amount of concern and coverage around the impact of cost of living on people's health, mental, physical. So much of that relates to housing. If people obviously aren't putting their heating on, they're more likely to see homes with damp and mold issues. We know about the health conditions linked to being cold, huge pressure on health services. Do you think that's going to set, you talk about 80,000 plus people living in social housing in your area, do you think that's going to sort of leave your patch better equipped to respond to some of those challenges?
Absolutely.
Oh, I think, yeah, definitely. So I picked up a worrying stat this week, a little stat, but going to get bigger, is that through our gas servicing programme, 5 of our customers have asked us to cap off their gas because they can't afford to heat their homes. So as you would expect from an organisation like us, we've referred them to our financial inclusion team, but those families will then be on the radar of public health. We'll make sure that whatever health interventions are necessary. So having that partnership, it's just having the people to talk to and a shared language that says, okay, so these people haven't got enough money. We can deal with the financial inclusion part of the work, but there are health consequences of this. How do we deal with those together? There'll be property consequences as well, but how on earth do we deal with them together? And I think, given the cost of living crisis, given the fact that winter's coming, we're going to see loads more of that. And I can't imagine we're the only landlord experiencing that. So it is then, what is the holistic solution to this problem? Actually, we're dealing with poverty, and the holistic solution is getting more money in people's pockets. But if we can't do that, what are the other things that we can do, and what are the other range of agencies that not only need to be doing something and need to know about those people in order to be able to do it, but need then to be talking to government and policymakers about, hey, this is what's happening on the ground, this is the impact that it's having, is this what you really meant to have happen?
And I think when you look at, you mentioned again the 80,000 people living across our area, Rachel, and many of those people will live in more deprived communities. And we know that people who live in a more deprived community on average live 7 years less. Their life expectancy is considerably shorter. But working proactively with housing, we can help tackle some of these issues, and thinking about things like fire safety, stop smoking and so on. People don't necessarily want to have conversations with health services about smoking. We all know it's bad for us, but if someone smokes 20 a day, it's costing them £3,500 a year. But by working together with Grand Union, we've looked at how you can change some of those pathways and build in stop smoking advice to things like financial inclusion services. And through that trusted relationship and conversation that a resident is already having, you can free up considerable amounts of money for people who may be really struggling, and looking at things through that more positive, holistic lens can help tackle the issues that people are facing right now that are so challenging.
That's really helpful. It really comes through, I think, really clearly there that this isn't a nice to have as a sort of optional add-on. It's absolutely central, isn't it? So sort of reflecting then on how this fits with core social housing work, and perhaps taking us back to some of the aims and ambitions set out in the government's social housing white paper, that obviously is translating now in some form through the social housing bill that's passing through Parliament. I'd be interested to know your reflections, perhaps if I can come to you first, Aileen, on how this fits in, as a group chief exec, looking across your responsibilities, priorities, budget setting. You talked there about not just the time but the money that Grand Union has committed to this. For people that might be listening that perhaps haven't yet started out on this journey, what would your sort of reflections and tips for them be in thinking about how it really centres in core purpose?
So if you look at it just at a very top level, if you think about that £3,500 figure that Liz just mentioned, if those people have £3,500 more in their pocket, we will get our rent paid, or we're more likely to get our rent paid. Actually, we're not particularly doing it for those sorts of reasons. But and then if we think about Bilberry Road, where a couple of Christmases ago we did foreclosure orders for cuckooing, drugs, alcohol. It was a miserable community. we could do all we could for the fabric of the dwelling, but actually what we couldn't do was get the interventions in place that supported people to stop taking drugs, that enabled some services that supported them to be more resilient so that they didn't get cuckooed, or actually we ended up moving quite a few people there. And as a consequence of that, what we have is a quiet, calm, well, happy neighbourhood. We haven't got any people wanting to transfer out of it. We don't visit in twos anymore. We don't deal with, through our customer services team or with our tenancy enforcement team, a plethora of complaints about really, really nasty antisocial behaviour driven by drug, alcohol deprivation, and the cuckooing and the regular activity by county lines gangs that was going on down there. So for me, this then becomes a central part of our toolkit to deal with those areas. And I just say it's really effective really quickly, in a way that, we can't get court dates. We can for really urgent antisocial behaviour, but we can't get court dates through the court system at the moment. Dealing with some things is really hard yards, with the range of partners who are normally around the table for dealing with this. Actually, public health didn't know about these pockets of antisocial behaviour. Why would they? And what was driving it? But now that they do, actually we're able to get really great interventions really quickly that sorts a problem much more quickly than it would do. You do flood with resource for a while, but it's really effective. I can't see why people wouldn't do it. For me, it's part now of that core housing management kit bag, if that's what we want to do to help people have better lives in the homes we provide. And that's what I come to work for.
That's brilliant. That's very inspiring. Liz, I'm sure you've got thoughts to add to that too.
I'd echo everything Aileen said, but I think, from my perspective, having had a long background in housing, for me the work aligns really closely with core social housing. It's about tackling inequality, tackling stigma, improving life chances, and really recognising the role of home and community in someone's health. I think there's, we've touched briefly on the alignment with income management, but linked to that, there's fire safety risk, building safety, asset management, life cycle costs, impacted all by how people use their properties, if they smoke or they're heavy drinkers, or if they've got, suffer with hoarding issues, those kind of things. And we've said, that if someone smokes 20 a day, that's £3,500 a year. We've recently been working with a Grand Union resident who actually smokes 60 a day. So that's £10,000 a year, that they've now saved. And we know from the research that Grand Union have done on their psychographic segmentation piece, and also national research, that around a quarter of residents in social housing smoke, and of those about half want to give up. People who smoke are more likely to be in arrears, and more significant arrears. And I think, if you refer to things like Marmot and Build Back Fairer, we know that good health starts at home, and we know that our home is the main setting for our health throughout our lives. And, many housing associations residents suffer from health inequalities, and they're avoidable and unfair. And we've talked about the impact that can have on your life expectancy. And I think, one of the things that most struck me when I started this work is if you look back to 1919, the first building programme for social housing nationally was kicked off by the then health minister, Dr. Chris Addison, not a housing minister. So our work has got well-established, well-recognised roots, and through this we can make a really positive and proactive difference to people who otherwise, for whatever reason, aren't accessing services that they're very much entitled to. And I think, referencing the cost of living crisis, we see it in all sorts of ways. And one of the worrying things we've seen recently, that again we've been working with Catalyst and Grand Union on, is around prescriptions and people not being able to afford prescriptions at the moment. And in a lot of cases they would be entitled to a free prescription, but the awareness is so low. So there's a whole raft of quick wins is possibly the wrong word, but quick ways to help people to what they're entitled to improve their quality of life, as well as the longer term strategic and process led changes that we can make to embed this work more widely.
Yeah, now if I could just come back on that. I grew up on Addison Drive and was asked a couple of years ago to unveil a plaque on Addison Drive. But it is that absolute proper link between housing and health. And this feels like we're bringing it back full circle and we're making that happen again. And your point about home and the Marmot review, when I did my CIH presidential speech, I quoted T.S. Eliot and talked about home is where we start from. You know, if home is right, everything else can be better. Education can be better. Our health can be better. Our life chances can be better. And so as a landlord, I feel we have a responsibility to make that home a place where people can really start from. And to do that, it has to be right. And to do that, we have to bring in a range of partners. Not have to, actually, I want to bring in a range of partners that enable home to really be the place that we can start from.
That is absolutely brilliant. And just for anyone listening who's intrigued by the reference from Liz on psychographic segmentation, do have a look on CIH's website. We ran a masterclass with Aileen and her colleague Naomi earlier in the week where they talked through that. So for any CIH members listening, and if you're not a member, now's the time to think about joining. You can find out more about that. I mean, such powerful stuff, and I think I could ask you a lot more questions about some of the case studies underneath, which are incredibly powerful when you just talk through some of those examples of people giving up smoking and obviously the whole range of benefits aligned to that. In terms of how then you see this work going forward, you've clearly started off a fantastic partnership that's going to stay the course. I've no doubt where you are, but in terms of that, for those listening who will no doubt be inspired by this, how do you see this work growing, and how do you hope to embed change so that one day when you're not here to be driving it forward, you can be confident that it's set up in this sort of new way of established working? Perhaps I can go to you first, Aileen.
So this has to last beyond us, which is why our colleagues, our frontline colleagues, are being trained in that smoking cessation work. They're trained in signposting to weight management work. So the links become established, and then it will just carry on because they'll always be there. So, for example, on hoarding programs, working with BLMK Mind, even during a pandemic, you know, those pathways are made now, and actually there's a very clear rationale and body of evidence at Grand Union for future decision makers when they're looking at a budget and thinking, why are we giving this 30 grand to public health? Well, here's all the reasons, and actually here's what it's delivering. And so, you know, we when we were thinking about doing this, and we didn't think for very long, actually, I have to say, but when we were thinking about doing this, it was, well, how long can we get something that we can write up a proper proof of concept so that we can demonstrate beyond any doubt that this is a way we can help people have better lives and solve a whole load of other issues as well. And that's why we committed for 3 years. I've no doubt we'll commit for more time following that. I can't see why we wouldn't. And actually, strategically, it's got Grand Union round the table talking to health colleagues in a way we've never had conversations before. And I, earlier this week, for example, was asked to be on the interviewing panel for the new Director of Adult Social Care, Health and Housing at Central Bedfordshire Council. Actually, it begins to really cement those links so that they become so natural that it's just the way then you do things.
Thanks, Aileen. Liz, did you want to add your thoughts to that?
Thanks both. Yeah, I think for me there's some work that we're starting to do around looking at how we embed health into strategy and process and all of those good things, and thinking about, if you look at, you know, customer touch points and customer journey, align those with the kind of tenancy life cycle model and the process maps, how can we then start to embed this change systematically into some of those pieces? So, for example, thinking about financial inclusion and stop smoking, we've done some great place-based work on the ground. We've done some early work with financial inclusion teams to embed that, but actually looking at those process maps and where we are today, how can we shift that in a way that is sustainable and embeds it genuinely in health and housing service delivery? So, we're starting to have some early conversations with Aileen's team about that work and looking at how that will impact on service delivery for the future. I think building on the place-based approach is massively important. I think one of the things that's been so successful through this work is recognising it's not a one-size-fits-all. That there are people that aren't giving up smoking because they can't go to their GP, or they don't, they can't get to the appointment, they can't access that service. But actually taking these services to people in their community builds those pathways to participation and access, and that's massively important. So I think, if you look more widely across these sectors and think about the role of housing associations as anchor institutions, that's now quite widely recognised, using that, we can develop our approach to really shape and influence policy. And at the moment, it's so important because, as well as tackling that, sort of horizon scanning strategic piece, making a difference on the ground to people who are feeling the cost of living crisis so acutely is hugely important. And so I think for me, it's a real balance of continuing that operationalising of the model and then joining the strategic dots to make it sustainable and embed it. So it's a kind of two-pronged attack that gives us, such an opportunity, and it sort of builds that flywheel of positive change that hopefully we can sustain for the future.
That's fantastic. And I think what's coming through to me is that you don't need someone to give you permission to do this or an instruction. This is very much kind of at the ground level, isn't it? And as you say, you can step it up to really have quite a wide reach. But this came out of a conversation that the two of you had and said, this sounds sensible, let's give it a go. And it's gone from there. But actually, there is some huge, massively important financial, physical benefits coming out of this. Yeah. So if we have, and I'm sure we do, as the sort of listening audience grows of these podcasts, say we had an official from the Department for Health and Social Care, Treasury, Department for Levelling Up Housing and Communities, or indeed a minister listening to this, and no doubt inspired, they've got some big decisions coming, and finance, of course, is a huge pressure. But what's coming through there, I think, is that this doesn't have to cost a lot. Actually, this can save a lot. What would your sort of asks for them be, if I can put you on the spot, for people that kind of at a central government level can be making some, making decisions that might be making this easier when money is so tight? Perhaps I can come to you, Aileen.
So that's fairly easy for me. We need a Liz in every public health team. So what we need is somebody responsible for that partnership, working with housing and looking at place-based built environment expertise in every single public health team, and actually making those partnerships more widely. Other housing associations, I am quite sure, will fund this model in their areas, but it is around that. Health seems to reorganise itself on a regular basis, and we've now got integrated care partnerships, and we've got all sorts of other delivery models. But actually having somebody in a public health team, however they get there, that knows about place-based interventions and working with partners is just the easiest, most no-brainer thing for them to do. And actually it's dirt cheap by comparison with not intervening and the consequences for the NHS, the consequences for landlords in terms of tenancy failure and tenancy enforcement work, the consequences for education, of disrupted education owing to poor mental health and poor home circumstances and kids not having enough to eat and all of that sort of stuff. The work public health do is brilliant, and actually I hadn't understood any of the complexity of it or any remotely some of the work that they were supposed to do, but it's genuinely preventative work where we are stopping bad things happening. Actually, having a stopping bad things happening team in public health is what everybody should do, and it's not hard.
And I think I'd just echo that, and I think, you know, I'd say it's help us break down those barriers. We're all trying to do the same thing, we're all trying to help the same people. Help us have that helicopter view of our populations and help us work to improve things. And I think, you know, as Aileen touched on, it's so important to move to this preventative model. If we can move to the preventative model and create a whole systems approach to this, it will make people's lives better and it will save the system money.
And just adding to that, our psychographic work is also telling us that we need to focus on prevention in our housing management work. Sometimes in housing we're quite good at rescuing people when they're dropping off a cliff. How about they never got to the cliff in the first place? And a partnership with public health is one of the ways that we can do that.
So I know one of the things that you've done, and people might want to have a look at it after listening to this, is that you ran a round table last year where you brought people together, and that produced a great paper that people can read called Sharing the Art of the Possible, Developing Stronger Health and Housing Partnerships. And I know you've got another one coming up. So I wonder if you might just share a little bit around, how those work, the kind of conversations you've had and are looking to have.
The roundtable brings together sort of cross-sector leaders who are very influential in these spaces and gives us the opportunity to do exactly as you said, share the art of the possible, share our ideas and really help to build on the brilliant work. And I think that's, you know, one of the things that's at the heart of what we're doing is to create an approach that can be shared and replicated. And by working together with more partners cross-sector and in housing, we can do that. So it's a real sort of springboard to building our approach and sharing it more widely.
What I would say is that at this stage in my career, I don't think I really expected to be quite so excited by doing housing in different ways. And actually, what we've done with the Health and Housing Partnership is we are realising Sir Christopher Addison's vision and Octavia Hill and all those wonderful people. And then the psychographic segmentation gives us who do we need to be doing this with, and what is it they need? And so I am just filled with hope and optimism for our sector. I know it's really challenging and it's rubbish out there, but actually we can still make a massive difference to people by doing some quite simple working together and then changing the way we think about who our customers are and what it is they need by way of services from us. So in taking that work forward, for me it's about those elements, it's about what people need now and what people want now and what people are asking you for now, and any proper business, landlord, whatever, it needs the tools to be able to respond to that, and this is what gives you the tools. I'd just like to thank CIH actually for being with us on every step of the way. I think Sarah Davis has really become really rooted in this work, can see its possibility, and has used the massive platform that the CIH has got to help promote this. I think we at Grand Union and certainly at Public Health in BLMK would want to say a big thank you for that.
That's great. Well, I mean, it comes through, it's all about partnership. So everyone's got something to bring to that, haven't they? That's fantastic. So can I just ask then, I mean, I'm sure people listening will be absolutely convinced by everything you're saying, but of course the hard kind of business end of stuff often says, but show me the data, show me how you know this is successful, how is it going to save me money, how are you going to track the impact, where are the KPIs? Can you talk us through the kind of data sets, perhaps quantitative and qualitative, that you're able to gather through this work and what you're looking to do going forward with it?
Thanks, Rachel. I think, we all recognise how important data is in driving effective and the right business decisions. One of the things that is quite challenging about this work is the metrics and how you measure it, but we've been lucky with our partners in that hasn't proved to be a barrier to doing the work. But as we move forward over time, we are establishing shared data sets, and that's one of our big priorities for the future. So whether it be insights data through the shared feedback from the psychographic segmentation survey for Grand Union, whether it's baselining arrears data or fire safety risk information, over time, we're committed to building that kind of shared health and housing dashboard and to moving to a point where we're genuinely able to use our shared data to inform the right decisions, both for our residents and for the businesses involved. And alongside that, the voice of the resident is critical, listening to what our residents are telling us, and that qualitative feedback is every bit as valuable. So I think, there's two sides to every coin. And here we've got a fantastic opportunity to really embed the use of shared data, be it quantitative or qualitative, to inform our decision making for the future.
I would just add there that we had a bit of serendipity, really, one of those lovely happy accidents where we were starting our psychographic segmentation work, and Liz said, "Oh, that sounds interesting." So we told Liz about that, and then she said, "And can I have some questions?" And so we incorporated public health type questions, and actually I'm really glad we did, because that's been a revelation for us, not just in public health terms, but also in customizing our service and making sure, for example, that we meet our Equalities Act responsibilities in taking account of those different support needs that people have got. So we had that, as I say, that lovely moment of serendipity where two worlds kind of collided, and we thought, oh yeah, that sounds like a good idea, we'll do that. So what we've got is fab baseline data, really great baseline data, and we can measure that. And just to reassure the GDPR people who might be listening to this, we've dealt with all the GDPR considerations. There's no personal data, it's shared around people's individual circumstances, except where there is an express referral between one agency and the other.
Brilliant. That's really helpful. So as we start to bring it to an end, we've kind of gone high. If I can bring it back low to sort of the personal, could you give us an example? Perhaps I can come to you, Liz, of one person that maybe sticks in your mind that you have seen really positively impacted through this work.
Yeah, there is a person actually, and over the summer at our health hub with Grand Union, we've seen over 200 residents engage with us, but one of them in particular stands out, and it was a gentleman who wanted to give up smoking, but had for whatever reason been unable to get an appointment at his GP, so hadn't been able to access support or nicotine patches to give up smoking. And through our work in this community, he came along to one of the sessions and talked to the Stop Smoking service, explained his situation. We were able to get him, I think then and there, the support he needed around nicotine patches and information about the service to access that straight away. And through that conversation, he then explained to us that actually he was suffering with his addiction issues, and not being able to get the Stop Smoking support was making that worse. That was having a knock-on effect on his mental health. And so really he was struggling quite a lot. And having had the conversation with the Stop Smoking service, they then took him on and introduced him to P2R, the drug and alcohol support, who were able to provide him with advice and referrals. And then they took him on to talk to Mind BLMK. So through the course of his journey that afternoon, he engaged with all the services that he needed to, that he just didn't know he could access then and there in the sort of safety and security of his own community. And since then, he has gone on to sign up to the 12-week Stop Smoking support service and has maintained his quitting status and is engaging with us sort of every fortnight through the health hub outreach model. So it really brings it home to you, the difference that you can make to somebody, and how hopefully we can replicate that and roll it out more widely.
I would just add there, so that wellbeing, that health and wellbeing hub is in a flat that we have given over on an estate, and that gentleman is now working with our wellbeing team around gardening and other things that help drive positive mental health, connecting with the outdoors and being well, growing food, all of those things that sort of square that circle. So if we wanted an example of something really holistic that helps, it's a real privilege to walk alongside people on this journey. When they engage, it's a real privilege that we are able to do this. And so and that's just one example. It's just brilliant, and there'll be loads more of those, probably not quite so extensive, but loads.
That's brilliant. And I don't know whether listeners can get a sense of the smiles that are coming through on screen as we record this, but this is a happy podcast. We've got some really fantastic stuff coming through, and it's really amazing and inspiring to hear the real world impact, the life-changing stuff that is able to come through from people just getting past any barriers that might traditionally have been there and working together, recognising it's all about helping people. So if I can start to just draw us to a close on what has been an amazing conversation, I'm going to reuse your quote, Aileen, from T.S. Eliot, that home is where we start from and good health starts at home. And I think, gosh, people listening back to this conversation will be so struck by just how powerful that is when we bring health and housing together in a really meaningful way, and teams on the ground through to the high level decisions being taken about resources. There's clearly some life-changing stuff that can happen, big and small, but also financially it makes sense. If you're just purely driven by the KPIs, this is going to save you money at a local, regional, national level, but more importantly, it's going to really make a huge difference to communities. We've had some great examples there around improved health, but also improved finances, reduction in ASB, better asset management, and clearly wider partnership working and all the things that come from that. And I think as we all try to work through the challenge that is coming even more now with cost of living, there's some really practical stuff in what we've heard today about how we can help people where we don't have to be constrained by just by financial pressures. Actually, if we ask some of the right questions, open some of the right doors, we can have some really holistic solutions. But it's about speaking that shared language and working towards those common outcomes where we recognise the person at the end of it and don't get overly tied up in the systems. So really look forward to hearing what comes out of that second roundtable that I know you're running in a couple of weeks, because wow, there's a huge amount that's come out of the work so far, and I'm really excited to see where this goes, and perhaps we can get you back in another year and hear about the journey, and perhaps hear from someone who's been with you on it and where it's all going. But really, really amazing. And thank you both so much for your time. And as you say, for everyone else who's been involved, and certainly CIH is delighted to be supporting any way we can. It's such important work. And as a reminder then for people listening, if you've not listened to a CIH podcast before, if this is your first one tuning in, do check out our other conversations which feature some really interesting topics and speakers, and we'll be back with you soon. Thanks everyone.